This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
It's a small incremental expansion in our skill set to safely include isotretinoin in our armamentarium, and the college course in February 2026 will upskill GPs to do that.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm joined by Dr. Diarmuid Quinlan to discuss safe prescribing of isotretinoin in primary care. Here's Diarmuid.
I'm Diarmuid Quinlan. I'm a GP in Maher in Cork for over 20 years. I am currently the Medical Director of the Irish College of GPs. I'm an online tutor in the Cardiff Dermatology Department, Diploma in Dermatology, and I was on the board of the Health Products Regulatory Authority for a decade before I ceased that role in December 2024.
My conversation with Diarmuid takes place as the Irish College of GPs prepares to commence a module on safe prescribing for isotretinoin in primary care as part of its Dermatology and Practice certificate. And this module will open on the 3rd of February 2026. And like the other modules in the certificate programme, the isotretinoin module can also be completed as a standalone and attracts 4 CE credits and a half day of GMS study leave. My conversation with Diarmuid today includes topics such as the value and importance of timely isotretinoin prescribing to suitable patient cohorts, the 4 key clinical competencies that underpin safe management of people with acne using isotretinoin, as identified by Diarmuid in a scoping review published in the British Journal of General Practice in September 2025, details of the Irish College of GPs Dermatology and Practice certificate more broadly, as well as the isotretinoin module in particular, practice resource considerations for those thinking of prescribing isotretinoin in their practice, as well as some recommendations regarding useful dermatology resources for primary care. As usual, you'll find links to the resources mentioned today in the show notes. Diarmuid began our conversation with a particularly memorable case from his own experience as an isotretinoin prescriber, which really highlights the potential value of early and appropriate prescribing for our patients.
I had a young woman, she was about 14, with really severe facial acne. And her mother brought her in to see me. And, at this stage, she said she developed the really severe acne in the last few months of primary school. And so I saw her, and as GPs do, I said, "How does your acne affect you?" A good open question. And she said nothing, I said nothing, the mother said nothing. We sat there quietly, and then the tears started to flow, speaking of the huge distress that this young woman was feeling. She said nothing. She just cried. And she was back to me 6 months later, having successfully completed her course of Roaccutane. Her skin now was vastly better. And as they were leaving, her mum turned and said to me, "Oh, Dr. Quinlan, I just wanted to know," she'd said earlier that every morning her daughter would spend 40 minutes putting on her makeup before she would leave the house. 7 days a week, she would not leave the house without her makeup. 6 months later, back to me, finished her course, 7-month course of Roaccutane. And as they were leaving, her mother said, "Oh, Dr. Quinlan, I just wanted to tell you, today was the first day she went to school, secondary school, without her makeup." And I asked the young 14-year-old, "And how do you feel about your skin?" And she said nothing on this occasion, but gave me a big smile. And to me, it just showed the impact that we as GPs can have in a very quiet way, but a huge impact on people's lives, and particularly with dermatology, because skin is so visible, it's common, it's a chronic disease. We know that over 90% of teenagers will have acne. 1 in 5 of them will have severe acne. And in many instances, it goes on for a decade or longer. At the age of 25, about 20% of women still have acne. So this is a condition that goes on for years and years for many young people. And we GPs can do something about it to cure it.
You wrote a really useful article in the British Journal of General Practitioners in September 2025, where you identified the 4 clinical competencies required for prescribing oral isotretinoin for acne. And we might delve into that in a little bit more detail today. But before we do, I just wanted to signpost for people the fact that there is a really useful module coming up in spring 2026 around isotretinoin prescribing in primary care as part of the broader Dermatology in Practice certificate run by the college, and listeners can potentially access the isotretinoin module and other modules as standalone if they would like to choose certain modules of interest to them. And I'll put all the details in the show notes, but perhaps you could give me a brief outline of that course and the isotretinoin module before moving on to the BJGP piece.
Certainly. So the Irish College of GPs has a really fabulous certificate in dermatology and practice running each year, and I would encourage people who would like to upskill. It's designed by delivered by GPs and consultants for GPs, and in February of this year in February 26, we are delivering a module on safe prescribing of isotretinoin in primary care. It will go on for about 3 weeks. We have got some of the world experts on acne who have very kindly agreed to, from the UK and from Canada, who very kindly agreed to participate. We will cover all the aspects that GPs need to know to safely and effectively prescribe isotretinoin for people with acne, taking them from selecting the correct patient, all the preparation you need to consider in advance of starting someone on isotretinoin, what options they may have tried before that, ensuring that they've done all the options. We'll talk about the blood testing, mental health assessment, pregnancy prevention plan, and dermatology to show that we have an accurate diagnosis. And that was really what the BJGP article outlined. It was the competencies that doctors need to safely manage Roaccutane. And we identified four competencies, which are dermatology, pregnancy prevention, mental health assessment, and blood testing. They are core competencies for all GPs. So we have already got the skill set to safely and independently prescribe isotretinoin with a little bit of additional education. And that's what this program is for.
So a really fantastic resource, Dermot, for anybody interested in upskilling in isotretinoin with a view to potentially prescribing in their own practice. So again, I will include a link in the show notes to that module of the Irish College certificate in dermatology. And let's pivot now to the British Journal of General Practice article that you wrote in September 2025 around the 4 key competencies you identified for safe prescribing of oral isotretinoin. And you highlighted in that article the unfortunate prevalence of inequity of access to isotretinoin for certain cohorts of patients.
So there is a huge inequity in access to isotretinoin. And this happens globally and has been shown to happen. And it was the big driver for change in New Zealand in 2008, where they have really good health data. The New Zealand could show that people from lower socioeconomic groups, ethnic minorities, people of colour, and women all suffered from delayed and inequitable access to isotretinoin. And that was the catalyst for change in New Zealand. And it's been shown that this happens across the world in other countries where they've looked at it. And I think we'd all be familiar that in Ireland, there is inequitable access, that, there are long waiting lists for secondary care dermatology clinics. And, so people who can afford to see a dermatologist privately have inequitable access. And, this is something that GPs can address safely and in a timely fashion. We do know that timely access to isotretinoin is really important, because the longer people have acne, the more likely they are to have scarring and the more severe the scarring is. So seeing people with severe acne, which they've had for 2 or 3 years, when they've extensive scarring, it's absolutely better to treat them at that stage. But prevention in terms of scarring, prevention is far better at curing. The other huge advantage of Roaccutane is in terms of antimicrobial stewardship. as GPs, we often agonize whether we should or shouldn't give somebody a 5 or 7 day course of antibiotics for a chest infection or sinusitis, where we commonly use doxycycline or related antibiotics. And the guidelines then say to put people with severe acne on equivalent antibiotics for 2 or 3 months. And this is often repeated. And while the ideal is only 2 or 3 months, that is still a very long duration of antibiotics. But often the evidence suggests that the average duration is in excess of 7 months because people get the prescription repeated. And we know that while they may work while people are on the antibiotic, and they work partly through the antibiotic, but also they have a degree of anti-inflammatory effect, as soon as they stop it, the problem, the acne recurs. So as an individual, we're not treating their problem, we're not curing their problem. As a society, we are compromising our antimicrobial stewardship. So we have a tool, Roaccutane, which can help us substantially improve our antimicrobial stewardship.
Okay, so I think you've done a really good job there, Diarmuid, of describing the problem. And of course, adding isotretinoin to one's prescribing armoury, as it were, might be part of the solution. In your BJGP article, you identified 4 competencies that are really prerequisites from the international guidelines around safe prescribing in primary care of isotretinoin. And I know you go into this in a lot more detail in the Irish College of GPs module, but perhaps we could begin with the first of the 4 competencies, which is dermatology.
It's important that we be able to accurately diagnose moderate to severe acne. And in the vast majority of cases, that's very straightforward at GPs. In fact, most teenagers will accurately diagnose it. But we just need to be sure that there are some things that may look like, particularly the perioral dermatitis can sometimes look like it, or rosacea can sometimes be mistaken. But in the vast majority of cases, it's relatively straightforward. And then it's to identify people with acne who meet the criteria for isotretinoin. And really, as you'd expect, this is people with severe acne. And I think we all know what severe acne looks like. And I would say that it is the patient who decides whether their acne is mild, moderate, severe. I never tell my patients, if they say how bad do I think it is, I reflect the question back to them, that it's their decision. People who have treatment-resistant acne, or where the acne comes back again, people with scarring. And scarring is very common, particularly if people have severe acne for any duration at all. So if you look carefully, you'll often find it. And then people who describe a significant psychosocial impact of their acne on them. And we know, and as I highlighted with that story, the psychosocial impact of acne is enormous, particularly for our young people, and particularly when they realize they can have this disease for a decade or more. They're the 4 indications to consider isotretinoin.
Okay, Diarmuid, thank you. That's our first core competency, which again was dermatology. And we'll move on now to the next core competency that you identify, which is blood testing.
So blood testing is in the guidelines, and many years ago it was a lot of blood tests, often, before people started, when they were finished, and including monthly perhaps. The blood testing has reduced very substantially in recent years because it's recognised that the benefit is very modest. Really what we're looking for is people with isolated familial hypertriglyceridemia, people with very high lipids. We know that going on Roaccutane increases people's lipids temporarily and slightly, often no more than 10 or 20%. Their LFTs or their lipids may go up. And as soon as they stop, it comes back to normal again. So currently, the guidelines suggest you do a baseline blood test before people start, and then when they're on their target therapeutic dose, and that if those results are fine, that's the end of it. And there is an issue in husbanding our laboratory resources, so that we're not doing blood tests unnecessarily. So I only do lipids and LFTs. That's all that's required. So we don't want to be doing lots of unnecessary blood tests. In the United States, about 500,000 people a year take Roaccutane. So you can see, if you decide you're going to do an extra full blood count on every one person every time, suddenly you can be talking about tens or hundreds of thousands of additional blood tests unnecessarily. So LFTs and lipids, and that's sufficient.
And the FBC to monitor for potential blood dyscrasias is no longer advised or necessary.
No, there's no evidence that that isotretinoin causes significant adverse blood outcomes in the vast majority of people, otherwise fit, healthy young people who take it.
Which is naturally the cohort we're talking about in the majority of cases here.
Exactly. Yes.
Right. So that's blood testing. And the next key competency that you identify in your paper, Diarmuid, is the mental health assessment. And I guess this tends to be a younger cohort of patients who may present, not uncommonly, let's say, with things like some degree of mental health stress or distress. So how do you fit this into your clinical practice when assessing somebody for isotretinoin suitability?
So the guidelines all recommend assessing mental health on people taking Roaccutane, and that relates to concerns that historically have been expressed about Roaccutane and adverse mental health. And the evidence is that we know that acne, severe acne, causes a lot of emotional burden and mental health burdens, particularly for young people. And there's a lot of evidence from reviews and cohort studies and systematic reviews that there is no causal relationship between poor mental health and Roaccutane. So no causal relationship between adverse mental health and Roaccutane. And that includes a very recent meta-analysis which said that there was no evidence of an increased risk of suicide or depression among people who use isotretinoin at a population level. And that was in 2024. However, because of the concerns that have been expressed in the guidelines, it is prudent to to assess people's mental health. And that is a core clinical competency of GPs. We talk about mental health with our patients all of the time, and we are very well capable to assess people's mental health and support people. And we know that severe acne causes people to become socially isolated and withdrawn. And most GPs will identify that as people's skin and their acne improves, their mental health improves. And I find that when young people come into me with severe acne, they're glum, they're downcast, they avoid eye contact, it's monosyllabic responses. They're back a month later, their lips are dry and maybe a bit cracked, and they are beaming from ear to ear because they know their skin is getting better. They're smiling, they're chatty, their parents are with them, and they are delighted because they see the young person coming out of their shell. So, improving people's skin improves their mental well-being.
And you might say the knotty aspect of this, Diarmuid, is that pre-improvement part when somebody comes in and maybe they are feeling a mental burden, let's say, from their skin disease, which we're hoping to manage with isotretinoin. But given that we're doing a mental health assessment, can that colour things? During my time in dermatology outpatients, for example, I would have seen the use of the DLQI or the Dermatology Life Quality Index. Would there be a role for something like that? Or, for example, the PHQ-9 as part of that initial assessment for the young person?
So the vast majority of young people, as GPs, and often they're with their parents, it's very clear this young person doesn't have a serious mental health issue, and just carry on. If there are concerns about mental health issues, then most GPs have psych training in psychiatry, and we're very well used and experienced in assessing people's mental well-being. And yes, there are mental health questionnaires that can be used, like the DLQI or the PHQ-9. However, these have not been validated for use in acne and Roaccutane. So people maybe who are less comfortable, clinicians who are less comfortable in doing a mental health assessment will commonly do these. I think most GPs are used to assessing patients. They'll have a conversation with the patient and often with their parent who's there with them and say, look, actually, if you are worried about their mental health, pick up the phone, bring them back. I'm readily accessible. We'll see them the same day, next day, within a day or two. And that gives great reassurance both to the GP, the patient, and their family. So I think we are particularly well placed in terms of assess and manage mental health concerns in our young population.
And another area, Diarmuid, where we're well placed to assess and manage our patients is around contraception. And that brings us on to our fourth key clinical competency, which is pregnancy prevention.
So Roaccutane goes into the nucleus of the cell and switches off the oil production in the sebaceous glands. So that's how it works. It's very effective. We know the fetal brain is substantially an oily tissue, and fetal exposure to isotretinoin, even a single dose of it, can have a severe adverse effect upon the fetus, causing severe congenital defects. So it's really important that doctors and patients who are doctors prescribing patients who are taking Roaccutane fully adhere to a robust pregnancy prevention program. And the detail of that really is that women who are sexually active should be verifiably not pregnant, and that usually means 2 pregnancy tests, 10 or more days apart before they started, and sometimes starting it on the day of their period. So as certain as one can be, using 2 forms of contraception, at least one of which must be hormonal, ideally a long-acting reversible contraception, but always 2, one of which must be hormonal, and then condoms as well, because we all know there is a failure rate with all forms of contraception. And then the big challenge arises for doctors and patients, particularly with young adolescents who are not sexually active, maybe young girls who have never had a boyfriend. And, there is tension, should these women be prescribed hormonal contraception? And we know that while hormonal contraception is very safe, it's not absolutely risk-free. And there is an ethical dilemma that doctors face in terms of prescribing contraception for women who tell them they are not sexually active. Thankfully, the current guidelines are clear that if a woman is not sexually active, there is no compulsion for doctors to prescribe hormonal contraception for these women. That is a challenge because the pharmacists, their regulation is somewhat different and is really quite strong that all women in the reproductive years should be taking hormonal contraception. So there is a regulatory tension there for patients, doctors and pharmacists, but the guidelines for doctors are that women who are not sexually active it's not compulsory for them to be prescribed and to take hormonal contraception. So it's a very patient-centred approach.
Okay, that's very clear, Dermot. Thanks for that. So that's the pregnancy prevention clinical competency. And again, the other 3 were blood testing, dermatology, and mental health assessment. And I'm sure many GPs listening to this might say to themselves at this point, well, those are all aspects of care that I provide routinely in other areas of my practice. So there isn't necessarily anything new under the sun here in terms of potentially prescribing for isotretinoin. And I guess that's the point, isn't it, of this forthcoming college module on safe isotretinoin prescribing in primary care. It's to give GPs the additional tools to build on those foundation blocks that we all already have in order to be able to provide this service potentially to those acne patients within our practice.
Yes, so the module will absolutely equip our GP colleagues who already possess those 4 skill sets. It will provide them with the additional clinical knowledge they require to safely and competently initiate and manage people independently on isotretinoin. And we're really talking about, the correct starting dose, titrating the dose up and down, anticipating, avoiding and managing flares of acne or purges, as patients call it, and dealing with the duration of therapy and acne recurrence afterwards. And and also we can use topical adapalene to help minimize acne scarring and help with the settling of the skin afterwards. So the course looks at how do you select a patient and prepare them for it, how do you manage patients when they're on the Roaccutane, and how do you manage them again once they're off it. So it will equip GPs with the skills and competency to safely and effectively do this. Really, so GPs who take it on and attend the course, I would hope that by the end of February, they will start to prescribe isotretinoin and with the support that we will give them.
And you've already really clearly outlined all the benefits that can accrue to patients where doctors are in a position to make that prescription for them in terms of isotretinoin where appropriate. And one jurisdiction that we've already mentioned that has gone down this route in terms of isotretinoin prescribing in primary care is New Zealand, where I believe they began their program in 2008. Perhaps you could outline how that started and the kind of data they saw over the subsequent 15 years of providing GP-led care.
So in New Zealand, they had very clear data showing inequitable access of the various groups to isotretinoin. And in 2008, they had about 7,000 people getting access to Roaccutane. They changed their national model to essentially enable GPs to prescribe Roaccutane. And by 2011, so within 3 years, GPs were prescribing about 65% of all the Roaccutane. And I've seen the data from New Zealand. Year on year, the number of patients getting Roaccutane has gone up and up every year. Year after year, it's gone up. And GPs now prescribing in excess of around 80% of all the Roaccutane in New Zealand. And the numbers of patients getting it in 2023 were in excess of, I think it's 27,000 patients in 2023 in New Zealand, having grown from about just under 8,000, showing huge unmet demand, unmet need for patients to get Roaccutane. So it's likely in Ireland that there is a very significant unmet need. We can do it safely. We can do it in a very equitable fashion. We can certainly do it in a very timely fashion. GPs have the skill set. We have the 4 clinical competencies. We are also, if people have concerns, particularly on mental health or contraception, we are readily accessible to them. We do this all day, every day. We know there's a huge burden of disease with acne for young people, and that treating them with Roaccutane makes a huge difference to their mental well-being, their confidence, their self-esteem, all of those very positive things. And that's what I find in my practice. Like I've been treating people with Roaccutane for well over a decade, and it's the young person is delighted with their skin, and they're thrilled with it. Their parent is delighted because they see the self-confidence returning, their self-esteem returning, their happiness, they're much more sociable. And that's the value that I take from this, that actually you have a very happy young person and you have a very happy parent. It's otherwise, it's a single disease. It's a single medicine. They're otherwise fit, healthy patients. It's not multimorbid, complex chronic disease with lots of additional problems. It's a very straightforward problem that is well within the competence of GPs to manage.
And in line with the Irish College's rollout of the isotretinoin module in spring 2026, Dermot, I noted that in New Zealand, part of the model involved appropriate education for prescribers.
So the New Zealand, they provided education on Roaccutane to GPs. Providing Roaccutane is also resource intensive. As a GP, you probably see them once a month for 6 or 7 months. Then there's 2 blood tests. So it's, between probably 7 and 10 consultations in total. So it is resource intensive. And, GPs need to work out how best to incorporate that into their clinical practice and into the financial stability of their practice. And that's what they did in New Zealand. So they resourced GPs to do it. They provide education and resources to enable this to happen in a safe, timely, equitable fashion across the country. And we can do the same here.
So there's a real opportunity here, Dermot, to optimize management of acne for our patients with the addition of isotretinoin prescribing for interested GPs. I wonder, could you maybe give me a couple of key takeaway messages and also maybe signpost listeners to some useful dermatology resources that they could avail of more broadly?
My take-home message is that GPs are already managing mild to moderate acne to a very high standard using topical and oral treatments. We already have the skill set to manage severe acne using isotretinoin, the skill set being dermatology, mental health assessment, pregnancy prevention, and blood testing. It's a small incremental expansion in our skill set to safely include isotretinoin in our armamentarium. And the college course in February 2026 will upskill GPs to do that. We do also know that there are lots of other additional resources for GPs in dermatology. The Primary Care Dermatology Society of Ireland are fabulous, as are the Primary Care Surgical Society. We have our GP dermatology colleagues in the community, but also we have the really fabulous antibioticprescribing.ie, which has a section, and a really good section, on the management of acne. So I would encourage my GP colleagues to consider doing the dermatology and practice certificate, and most especially the isotretinoin prescribing safely in primary care, so that we can expand the service we offer to our patients going into the future.
Indeed, Dermot, and hopefully today's conversation has piqued the interest of more than a few of our listeners in terms of upskilling towards isotretinoin prescribing in primary care for their own patients. And of course, the college programme in February 2026 would be an ideal roadmap towards that. Before I let you go, I wonder, could you tell me a little bit more about how you managed to maintain a work-life balance in the face of what's clearly a very busy schedule between your clinical work, your college role, and I believe you're also studying towards an MD with University College Cork. And also, some of our listeners might be interested to know where your own interest in dermatology arose from.
I've always been interested in dermatology. And I distinctly remember when I was started work in my GP training, not being able to tell the difference between eczema and psoriasis. So poor was my dermatology knowledge. So I realized that this was something that I needed to upskill in. And, I went and subsequently did the Cardiff Diploma in Dermatology in the UK. And have been a tutor in Cardiff ever since then. So I've had a long-standing interest in dermatology. Skin presentations account for probably at least 1 in 8 of all the consultations in general practice as part of our work. So it's a common and important issue. And acne is a really common condition. And I've had an interest in acne and severe acne and treating people with isotretinoin or Accutane for that. And my GP colleagues in UCC, Professor Tony Foley, encouraged me to do an MD in this. So I felt, given the appropriate supports within the university, within my family, that it was an achievable target. And so I started it, and I'm loving it. Like it's great. I would encourage anybody to consider doing it. Yes, it is work. It's probably 8 or 10 hours a week in total, which when you're already busy is a substantial additional ask for several years. I don't look at it as work because it's a completely different activity. And then in terms of maintaining work-life balance, it's really important that we as doctors maintain a good work-life balance and that we make the time and space for, our family, our leisure pursuits. And I do that, I take time off with my family. I do take my holidays. I, take time off weekends. My 2 favorite sports really are kite surfing and most recently mountain biking for when there is no wind, I can go mountain biking. So they give me my headspace. And then within the Irish College of GPs, working as a medical director, the team around me and my colleagues in the Irish College of GPs are incredibly supportive. And, the GP community is like one large family across Ireland, and they are very supportive. So it's a really good team, and I'm enjoying it immensely.
Many thanks to Dr. Diarmuid Quinlan for speaking to me today. And don't forget to check the show notes for chapter markers as well as links to resources. If you have any comments or feedback on today's show, or indeed any suggestions for future episodes, please do get in touch. You can contact us at podcast@icgp.ie. And that's it for today's show. Many thanks again for listening, and until next time, take care.